Yeah, I think now it is coming. So now, I was discussing the questions of physiology, anatomy I have discussed. So it is probably break now. So the question was like this, and the question was just a minute. A patient of HbA1c 11.4 has come to your clinic with severe pain at night, and which nerves are involved in this patient? So it is A alpha fibers, A beta, AG, and C. So here, as I told you, C nerve, and those who have not seen the previous video, I have discussed only one questions of anatomy. That also I will give you in the group. And that was the question on the tooth sensation about the tooth loss. You will see I have explained here, but due to my mobile failure and some server disturbance or some not keeping the mobile properly, it has been kept in the separate video. So now, why now the answer would be C fibers. Now, why it will be C fibers? Because it is a clear-cut case of diabetic neuropathy, where it is a microvascular complication that affects the unmyelinated C fibers. So, if in the diabetic neuropathy, which you already understood, it affects the unmyelinated C fibers, and which mediate the pain sensation. So, just if you have a previous, if you just have a previous or just prior knowledge that what are different types of fiber, so you can easily understand that the A fiber, alpha is for the proprioception, somatic motor, beta is for touch, pressure and motor, gamma is for motor to muscle spindle, delta pain touch, beta fiber for preganglial, and in the C fiber for all type of pain. It can occur in the dorsal root, pain, temperature, reflex, and the sympathetic root, postganglionic sympathetic. So in the C fiber is affected because the patient is suffering from diabetic neuropathy, because we have already seen that the patient is suffering from diabetic neuropathy, and actually it is uncontrolled diabetes, so it has affected the C fibers. So you will understand, you have to first study the different nerve fibers, what are the different types of nerve fibers, and then you will understand so which nerve has been affected. So here C fibers. Now quickly, anatomy I have discussed, physiology also I have discussed. Now I will be discussing one question again on the biochemistry, and then I will be switching over to UPSC, and I will be discussing 2-3 questions there also, and then I will be coming. So now in the biochemistry I will be discussing about the now here actually I am not actually interested in discussing this one liner or two liner, because they are now obsolete, they do not come most frequently. So I will be discussing some conceptual question. Now I will be discussing about the more liner questions. So here comes the question of the biochemistry. Now try to listen it carefully, and then you think, and then I will be giving you the answer. Here actually this one, just a minute. Now here the patient has the patient had a history of strenuous exercise. The patient came in your clinic and with a complaint of severe exercises, but forgot to take his meal, and later had a alcohol in the party. So patient has a exercise, and patient forgot to took the meal and had a alcohol. So which of the following process is inhibited by alcohol? Now here, which of the following process you have to tell which is inhibited by alcohol? So is it glycogenolysis, or it is a gluconeogenesis, or ketone body synthesis, or it is HMP shunt? So just you think for a while, then I will be explaining. You might be, because this is not so difficult question in biochemistry. I am asking the lipid chemistry here now, right now topic. So here the question is very easy. The patient has undergone the strenuous exercise, and after that he forgot to take the meal, and he went in the party and had an alcohol. Now, so what will be the what following process will be inhibited by alcohol? So what will be the answer? Here the correct answer will be gluconeogenesis. Now, why it will be a gluconeogenesis? The basic fundamental to understand that why it will be gluconeogenesis, because the patient is having history of strenuous exercise. So strenuous exercise, and top of that he did not take the meal, which is suggestive of hypoglycemia. So when the patient is not taking the meal and when he had the strenuous exercise, he will develop hypoglycemia. In addition to that, he consumed alcohol, which is further aggravated to the hypoglycemia. And in chronic alcoholics, the ratio of NADH and NAD is higher. So here we presume that the patient is a chronic alcoholic, and here the ratio of the NADH to NADH will be naturally it will be high. And once the NADH NAD ratio is higher, pyruvate will get converted to lactate and OAA. Now lactate to OAA means the oxaloacetic, and it is get converted to maleate, resulting in the low pyruvate and low OA in this patient. Now the essential elements for gluconeogenesis are pyruvate and OA, and since it is low, so gluconeogenesis does not happen in this case. So here the gluconeogenesis is not happening, and here the question is also asking the same thing. Just a minute. Just a minute, where I have gone. Yeah, the question, which of the following process is inhibited? So alcohol is inhibiting which process? So alcohol is inhibiting the gluconeogenesis. Why? Because this is the reason. So you should understand the concept behind that why what is the after if he does not take the meal and he does the strenuous exercises, and he went for a party for alcohol, so what happened? He will develop hypoglycemia. Why the hypoglycemia is occurring, which I told you, and what is inhibited here? The gluconeogenesis is inhibited. So now I am just I have not completed, rather I have just shifted. Now I will be discussing some questions on this UPSC, because here I have discussed just anatomy, physiology and biochemistry, and in UPSC I will be discussing the some question on this one, the paper 2, some question on paper 2 which came in the year 2009, because paper 2 I will discuss, and here also I will be discussing some, and then I will be going to paper 1. Paper 1 I will be going, and I will be repeating the same. Now here the question is a bit conceptual, so I will be discussing this question. Here the question is of, I think it is the question is of obstetrics and gynecology, which has been given in the paper 2, as it is for sure that it comes in the paper 2. Now the following changes may be seen in the preeclampsia. Now what are the changes which is seen in the preeclampsia? Now it is seen that the following changes may be seen in the preeclampsia except. Now the question here, as I told you earlier also in my earlier video, that the question asking, the style of the asking the question which I am discussing here and which I discussed just now before, which you saw, it is still incomplete. Here also I will be not giving a long video here, because it takes a hell lot of time, and you will be also get bored. So here it is the difference between these two type of question here which I have asked. Here the question is very conceptual, where here the question is very direct. So here they are only asking the following changes may be seen in the preeclampsia except. Now what is not seen in the preeclampsia? So hemodilution is not seen. Why hemodilution is not seen? Because antithrombin 3, thrombocytopenia, elevated uric acid, all are the features of preeclampsia. So if you get a preeclamptic patient, so you will get all the features. Now, some blood parameters which is seen in the preeclampsia is hemoglobinuria. You will get hemoglobinemia. You will get intravascular hemoconcentration, extravascular hemodilution, and raised hematocrit value. You will get. You will also get thrombocytopenia, decreased ferrogen level, that is factor 1. Then decrease in antithrombin 3 and plasminogen level, and fibronectin D dimer, thrombin level, they will be elevated, and blood urea nitrogen may be normal or raised. Serum creatine will be raised, and serum uric acid is also raised. Serum APTT and PTT is raised. Serum chloride is raised, and serum HPL is decreased, HCG may be increased. So these are some of the parameters which are seen in the pre-eclamptic patient. So these changes. Now there is no changes in the hemodilution, because hemodilution does not changes, it remains the same. These are the following things which are changing. So the question is very easy, because the question has been asked that the following changes may be seen in the preeclampsia except. So here I have discussed this question, and this is a very easy question. Just you have to understand that what the features of preeclampsia. That's it. Because if you understand the basic changes which a preeclampsia patient does, which a preeclampsia patient presents to you with, so you can understand. So, and what is not happening, because here you can see what I am doing. This hemodilution here is important blood parameters extra. Here this hemodilution is extravascular. Hemodilution is happening, but it is not intravascular, it is extravascular. So extravascular hemodilution is there, and the hematocrit value is very high, because the blood volume is high, so high hematocrit value. So hemodilution, plain hemodilution is not the answer, because it is taking extravascular. So this will be the answer. Now these are some of the questions which you have to know, and these are the concepts which is always asked in the various way, on the various like what I should say, a typical shuffling way they will ask, or the same type of question they will ask. So now yeah, this is also one of the important question which was asked in the paper 2 only. Probably it is a question of surgery, general surgery. Now in a patient with a CA breast, now they have asked the question directly that the CA breast patient, what are the poor prognostic factor? All are the poor, the following are the poor prognostic factor except. Now what are the poor prognostic factors? First you have to understand the poor prognostic factor of a CA breast. So here the options are high grade, absence of this one epidermal growth factor receptor, aneuploid status, and age less than 35 years. So the following are the poor prognostic factor except. Now here if you discuss, if you see that the prognostic factor in node negative, if there is a node negative breast cancer, one it is node positive, one it is a node negative. So here the if it is a recurrence, increased chance of recurrence occurs in the T3, T2. Okay, in that if you discuss with the TNM status, so T3 and T2, the chance of increased recurrence is high, whereas the decreased recurrence is T1, or if there is a T0. Now hormone receptors recurrence is negative and decreased recurrence is positive. So if there is a positive hormone receptor, the recurrence will obviously it will be decreased. So now the question which I was coming, that epidermal growth receptor factor recurrence is one who have the EGFR, high, will always have increase in recurrence. So so the question is, in a patient with the breast cancer, the following are the poor prognostic factors. So recurrence is increased, and here the there is the question is in the B, which is written absence of epidermal growth receptor factor. So if we don't have, that is if the status is HER or ER or PR, it is negative, so the prognosis will be very poor, and there is a chance of recurrence. And in the case of where there is a absence, so it is poor, and where there is a presence of the epidermal growth factor receptor, the naturally the chance of survival and the prognosis will be good. So here these are the some of the question which you have understood now, that how they are asking question. Both question I have discussed, and both question they are asking very directly in the UPSC form. I discussed in the FMG also. FMG questions were not direct question, they were indirect question. Okay, here they are asking that in a patient with breast cancer, the following are the poor prognostic factor, except. So what are the poor prognostic? Just a high grade. High grade is a very poor prognostic factor. Like aneuploid state, that is also very poor prognostic factor. Age less than 35 years is a good prognostic factor. So, and what are the except? What are the poor prognostic factor except? Because if you absence of epidermal growth factor is a poor prognostic factor. So this you have to remember. So here I will be this two questions. Now let me go here. I discussed again. Let me come to the FMG question again. Now in FMG question, because I have discussed anatomy, physiology, and biochemistry. Because due to my mobile error, the anatomy has got to another video, which I will be adding to the and giving you in the group. Now let me come to the question of biochemistry. I have done. I will be coming to I will be discussing the one more question, and then I will be ending this video, because 2 3 question I will be regularly 3 4 question, like from 2 from here or 2 or 3 from FMG I will be discussing, and then I will be making the video more and more, so that it will not be boring for you. You can understand, and if you have any doubt, like the video which I am sharing it to you, if it is not sufficient or you want more explanation, then you can ask me in the group also, or you can ask me in the separately in my WhatsApp also. Now here this is a very important question which you can appreciate. Hypertensive patient who is on beta blocker. Now a hypertensive patient comes to your OPD and he is on beta blocker. Now suddenly he develops bradycardia, which is obvious, and he starts to sweat whenever he takes the medication. Now which beta blocker does not produce such symptom? Now here the options are ethanol, acebutolol, metoprolol, and nadolol. So you think for a while, because the hypertensive patient comes, and whenever the hypertensive, we are just very concerned that the hypertensive patient who are on beta blockers, we always check their heart rate, because they are more prone to develop bradycardia. So here what will be the, and it is the question of this question I think it came in came the equivalent question, it was asked in the 2018 2019. So this question came in 2019, and what will be the answer, you just tell me. So here the answer will be acebutolol. Now acebutolol is such a beta blocker which does not cause any sweating. Now the reason for that some patients are sensitive to beta blockers, as we all know, and they are prone to develop bradycardia upon intake. Now such patients are known beta blocker sensitive. Now however some beta blockers possess some beta blockers possess the intrinsic sympathognomic activity, also called as the partial agonistic activity. For such sensitive patient, beta blockers with partial agonistic activity are preferred always. That is very important. These drugs themselves activate the beta 1 or beta 2 receptor submaximally. So the benefits is the bradycardia and depression of contractility at rest are not prominent. So if you give that drug, due to this intrinsic sympathognomic activity, which is also known as the partial agonist activity, the sensitivity, and they will be activating the beta 1 and beta 2 receptor, and the benefit will be that the bradycardia and depression will not be occur, and withdrawal does not and here one of the side effect of the beta blocker, which already you know, was that we cannot directly withdraw the beta blocker, which can exacerbate the rebound hypertension, which is not in the case of the beta blocker which this drug produces. Acebutolol is the particular drug which is particular beta blocker, which does not exacerbate hypertension or angina. So now the beta blocker with partial agonistic activity, now you have to remember that there are like celiprolol, oxyprenol, pentobutalol, pindolol, cartilol, acebutolol, or popipindolol. So these are some of the beta blockers which are they have the partial agonistic activity, they are not having any antagonistic property which might produce sweating, and ultimately patient can go to even coma and etc. So acylbutylol can be followed. So here in this question, as I discussed, that a hypertensive patient who is on beta blocker develops bradycardia and start to sweat whenever he takes medication. Now which beta blocker does not produce? So ethanol produces. Yes, ethanol is a highly culprit drug because it is a cardioselective, and metoprolol is also highly cardioselective, and nadolol also, because nadolol also produces. So only acylbutylol, due to its partial agonistic activity upon B1 and B2 receptor, so it does not produce. So this type of question you remember. Now I have discussed here the three questions on FMG, and two questions on UPSC CMS, and I will come again and I will be discussing with you more and more questions, and this question I will be posting in the UPSC CMS group. Here one thing just again I want to mention, that the anatomy question which I have given, due to my mobile some error, it has gone to another video which I will be sharing as a dual video. So please do not confuse, because that is a question which I have discussed in of FMG only. It was in the FMGS, and rest of the question I have asked some questions on UPSC 2009. Remember 2009 paper 2, and FMG question recent 2023, 24, 2019, etc. And I will be again coming after 2-3 days, and again I will be discussing more and more question. I will be restricting my question to only 3 to 4, because if I take a long, because explanation also I have to explain. So explanation is my main thing. Like telling and giving the answer does not work well. I have to explain it, and apart from that, my task is please watch this video, and if you have any doubt, you please ask in the open forum there in the group only, or you can ask in the in my chat. आप दोनों कर सकते हो, या आप मेरे ग्रुप में पूछ सकते हो, या आप मुझे पर्सनली फ़ोन करके या व्हाट्सएप करके मुझे पूछ सकते हो. So thank you for today, and I will be again coming after 2-3 days. Thanks a lot.